Welcome to the quarterly Airway Research Update with Dr. Calvin Brown.
Great, thanks Terry, and hello everyone. It is great to be with you today. This is an extra special webinar because it will be followed at the end by the Airway Article of the Year Award Show. My name is Calvin Brown. I'm the course director for the Difficult Airway Course Emergency and attending physician in emergency medicine at Brigham and Women's Hospital in Boston and associate professor of emergency medicine at Harvard Medical School. If you've been to one of these research updates before, then we've met each other before, but if you're here for the first time, welcome. Today's webinar will include 3 new studies and a clinical vignette. We encourage everyone to post comments and questions. I will try to get to those at some time, either during the presentation or at the end. I have no CME disclosures, but thought you'd be interested in some of the other things that I'm involved in as a partner of AMEC, and I do emergency medicine writing for up-to-date emergency medicine. This webinar has been approved for 1 AMA PRA Category 1 credit and 1 hour of CAPC advanced credit. Everyone in attendance will receive a certificate by email within 3 weeks. At the conclusion of this webinar, you should be able to describe the latest research in airway management and apply the findings to your practice. Here's the agenda, which is the same as our agenda every time. We start with a pretest, which will include 4 questions. We will do a research review, Q&A, post-test questions, and then an evaluation, which you will see, which I will not see, upon exit from the presentation. And again, your certificate will be emailed to you within 3 weeks. Okay, so let's get started with a short pretest. So here's question number 1. And remember, you're not going to see the answers this time because this is just to get a sense of where everyone's baseline knowledge is. And then we will show the answers when we do the post-test at the end. So pretest question number 1, during CMAC video laryngoscopy, maximal glottic exposure is facilitated by A, using a size 3 instead of a size 4 blade, B, engagement of the median glossoepiglottic fold, C, applying extra lifting force into the mandibular fossa, or D, placing the blade tip underneath the epiglottis. All right. Now, you can't see how everyone is answering, but I can see, and it's kind of, it's a little all over the place, which is good, which means we're going to learn something. Okay, let's move on to pretest question number 2. Trauma patients intubated with DL compared to VL had higher rates of A, needing a cricothyrotomy, B, dental trauma, C, esophageal intubation, or D, hypoxia. Good. Okay, great. I think most people got that. Pretest question number 3. When intubating blunt trauma patients, which device provides the best chance for first attempt success? Which device category? A, video laryngoscope, B, a direct laryngoscope, C, a flexible endoscope, or D, an intubating LMA? There's always one gimme question in the crowd, and this is probably the gimme question. Okay, so I didn't fool anybody with this one, and we'll go back over this again in the post-test. And last pretest question, in ED patients, which of the following will not impact the rate of post-induction desaturation? A, which one will not impact the rate of post-induction desaturation? A, morbidly obese body habitus, B, pre-induction hypoxia, C, supine versus ramped position, or D, septic shock. All right, people are straddling mostly between 2 particular answers. So that's good. We'll have some learning on this one too. Again, these questions are all framed around the particular information in the studies that we're going to review. Okay, so let's get started. As I mentioned, there are 3 new studies today. We have a clinical vignette to facilitate discussion. And the topics, as you may have guessed from the pretest questions, include the following. The best device for trauma intubations, and we've looked a lot at VL, DL, and different devices, but there's not been a lot of information about trauma airways in the ED by emergency physicians in particular. But we have a large registry evaluation looking at that. That was in Annals recently. We're going to look at airway anatomy and laryngoscopy, And although we've reviewed this before, we're going to talk a little bit more about advantages, if there are any, between keeping a patient ramped versus keeping them in the supine position during emergency airway management. Okay, so let's start with a clinical scenario. You are working in the ED, and a 33-year-old woman who is currently obtunded is being brought in by EMS with reports of severe head injury following a fall from a second-floor balcony onto a sidewalk. The patient has been placed in a C-collar based on the pre-hospital information. You hear that the patient is oxygenating normally and currently has a normal blood pressure. There are no obvious signs of chest or abdominal trauma. It appears to be just head trauma and, of course, the potential for neck trauma. Upon arrival, the patient has a GCS of 6 and is starting to posture. So, first question for you, what's next? Intubate the patient, send to CT immediately, or apply some Curlex. So you can see that virtually 9 out of 10 of you said you should intubate the patient now, and I think that's probably the right thing. You're going to get a CT, of course, for the rest of you who said send a CT, but for someone who's got a GCS of 6, they're already posturing, you don't want to send them with an unprotected airway outside of the ED in case they vomit or they deteriorate even further. You can always have them follow up in Curlex clinic, but that's probably a lot further down the road. Okay, so you decide to intubate, and you're supervising, and your resident's getting the CMAC fired up, and he asks, can we intubate this time with DL? I haven't done that in a while. And you reply, sure, no problem. Or, not while I'm supervising. Okay, maybe we have some residents out there who are listening. All right, 80% of you said, not while I'm supervising, and 20% of you said, sure, no problem, why not? It's been a while, you need to learn how to do it. Well, our first paper that we're going to look at is entitled Video Laryngoscopy is Associated with First Pass Success in Emergency Department Intubations for Trauma, a propensity score matched analysis of the National Emergency Airway Registry. And I'll just say that we have a couple of near papers in there, and I'm trying not to be biased. I usually don't have a lot of near stuff, but there just was not a lot to choose from this last quarter. But this is a good study, actually. If you've been familiar with near in the past, you know that at least this latest iteration of NEAR is a large multi-center observational registry. It's about 25 centers. We have more than 19,000 encounters. In this particular paper, they looked at roughly 4,500 trauma encounters and then tried to find associations with first attempt success, particularly stratified by device. Now, because this is not a randomized trial, these are observational data. To enhance the validity of your findings, you want to try to mimic randomization or at least account for confounding by indication as much as possible. And that's what propensity score matching does, and that's what was done in this paper without getting down in the weeds too much. And this was accepted for publication in Annals a few months ago, and I believe is in print this month. So fairly fresh information. Stacy Trent is an emergency physician in Denver at Denver Health, and the other authors are all members of the NEAR Collaborative. When you look at the trauma intubations and the characteristics of these, you find that first attempt success overall was around 87%. The vast majority of first attempts were performed by emergency physicians, 94%. Video laryngoscopy, 7 times out of 10 was the device chosen. So this is starting to become standard practice now. This is not a 50-50 delineation anymore. And rapid sequence intubation was the most common approach utilized on first attempts. These are just descriptive data. When you look at the breakdown of sites, which are de-identified by using letters of the alphabet along the x-axis, and then stratified by number of intubations. So high volume centers are to the left, low volume centers are to the right. And then orange bars represent the percentage of, or the numbers of trauma intubations that were performed with DL, and blue represents VL. So you can see overall, with the exception of a handful of high-volume centers way to the left, although not the most leftward center, you can see that VL is the predominant device, especially at low to moderate volume places. At the top, surrounded by 95% confidence intervals, is the first pass success, which is framed around the second y-axis on the right side of the graph. The interesting thing, and I'm going to show you the take-home graph in a minute, but especially in this left-hand group of high-volume centers, it looks like uses DL more often. It's interesting that I kind of drew a fake slope in here, but kind of matches the first attempt success as you travel across these centers. And I think this is ultimately what drives a lot of the results at the end of the day, which is that when you look at any VL versus any DL intubation across these centers for trauma, you can see that there's a significant increase in first attempt success with non-overlapping 95% confidence intervals when VL is used compared to DL. Now, the different approaches with VL and DL, the different recipes you can use, are you using ELM plus a bougie, and all those different combinations are fractionated below this. But when you summarize the data, you can essentially get the take-home message by looking at the two top rows. And the first attempt success was essentially 90 versus 78%. Sorry, 90 versus 79%. And this held up with propensity score matching. It was still associated with this degree of first attempt success, VL versus DL. So my critical concepts for this paper is that trauma intubations are high risk. That was not proven in the paper, but that's something we all know. Crike rates are higher in trauma patients. Rates of failed airways are higher in trauma patients, and mostly because there's either anatomic distortion, there's blood in the airway, or they're in C-collars. And all of those impact your ability to see the glottis, which has a direct correlation with how successful you are at placing a tube. This latest NEAR analysis suggests that VL should be the standard intubating device for emergency trauma airways. Now, you could make an argument that if there is copious amounts of hemorrhage that you cannot clear or stay above with proper positioning and good, robust suction, then in those rare cases, direct laryngoscope or a salad technique might be the right way to go. But as a general rule, VL is what you should be using for these patients. So it should become routine in your practice, and honestly, not just for trauma, but for medical intubations also. Okay, let's get back to our scenario here. As you get ready to intubate, the senior resident asks, maybe I should keep this patient ramped. Now, in a trauma patient, you can't really ramp them, but you can do what's depicted in the picture here, which is place them in reverse Trendelenburg. And he lets you know, of course, that he's been doing his homework, and he read once that it may stave off desaturation. And how do you respond to this? Sure, let's do it. Let's keep them ramped while we're intubating. Actually, you know what? Supine is technically easier, and I don't think it's going to impact desaturation. Okay, so you should be seeing the poll results now, and about 70% of you say, sure, let's do it. Let's keep the patient ramped while we intubate. And about a third of you say, a little bit less than a third, say, you know what, it's easier to do it flat, which it probably is. And I don't think it's going to make that much of a difference. I think there are other things that tend to dictate desaturation rates besides ramping. Well, let's take a look and see what we find out. This is a paper that was recently in Academic Emergency Medicine. It's also a NEAR registry paper. And the title is Comparing Post-Induction Hypoxemia Between Ramped and Supine Position Endotracheal Intubations with Apneic Oxygen in Place in the emergency department. So apneic oxygen, of course, other things such as good pre-oxygenation, upright positioning while doing so, are all maneuvers to prevent desaturation. But what is unknown is whether ramping in particular, when coupled with the use of apneic oxygenation, it improves this. Does it actually make desaturation slower? So you're already using APOX. Does position make a difference in patients where APOX is being used? And that's what was analyzed in this paper. So here is the enrollment algorithm. As I mentioned, in NEAR 7, we had just over 19,000 encounters. So there's 19,071 single intubation encounters across the registry. Now, there were 3,880 patients who were medical intubations where APOX was used. They were adults, and the patient was intubated with either DL or VL. And then you can see below that the numbers were fairly equal. But more patients in both groups were intubated supine than ramped, and actually the proportions are about the same. But there were a couple hundred ramped cases actually in each cohort. When you looked at the significant variables that impacted the rate of desaturation using a stepwise multivariable model giving you adjusted odds, you can see on the most right-hand column that morbid obesity, a poor Cormack-Lehane view, and either appropriate levels of pre-oxygenation or pre-intubation hypoxemia all dictated whether the patient was going to desaturate. All the things we know, right? We know morbidly obese patients desaturate quickly. We know that pre-induction hypoxemia means they're going to desaturate quickly because they're already on the steep part of the hemoglobin desaturation curve. And what's not on here, but was in the pretest, is that critical illness we know because it's in a critical ill state like septic shock, there is high rates of peripheral oxygen utilization and extraction, and that impacts desaturation as well. But what made no difference, it turns out, was ramping with an adjusted odds of 0.96. When you looked at the VL cohort, you found fairly similar findings, actually eerily similar. Ramping seemed to make no difference when APOX was used, of course, remember that, with an adjusted odds of 0.97, but morbid obesity, poor Cormack-Lehane view, which is unusual with VL, but happens from time to time, and hypoxemia and subjective impression of difficult airway difficulty were all things that impacted whether or not post-induction, on first attempt, post-induction hypoxemia occurred. So Calvin's critical concepts for this: ramping or upright positioning, while we believe it is critical during the pre-oxygenation phase. In other words, you will develop a deeper, larger pre-oxygenation reservoir when a patient is upright, especially if they're morbidly obese. Morbidly obese patients who are supine are incredibly hard to pre-oxygenate. So robust pre-oxygenation is really key, as is the patient's body happiness and level of critical illness. But it appears that ramping during intubation, when APOX is used, doesn't impact the rate of post-induction desaturation. So you can keep the patient ramped if you want, but what you should really do is focus on good pre-oxygenation, then put the patient in the most comfortable, most effective position for you for performing laryngoscopy. Okay, moving quickly, let's get on to the third study. Let's continue our clinical scenario. As your resident inserts the CMAC, a grade 3 view is obtained, as you can see there in the picture. And these images are taken from the manuscript itself, and they're cited at the bottom of the slide. You apply external laryngeal manipulation, that's what ELM stands for, and the view doesn't improve. What is the problem here, do you think? Why are you getting a grade 3 view? A, the blade isn't deep enough. B, the epiglottis is just too big. Or C, the blade is off the midline. It does appear to be off the midline a little bit. Okay, so you all should be viewing the results now. About 80% of you, roughly, say that the blade just isn't deep enough. 3% say the epiglottis is just too big, too floppy. There's nothing I can do to get it out of the way. And 19% of you say that the reason why you can't get a view is because it's off the midline to the left a little bit. Now, only 60% of you voted, so I don't know what the rest of you are doing. All right, let's move on to the third paper to see if we can figure out what's going on here. So this is a neat little study. This was recently published in Annals of Emergency Medicine, and it's entitled Engagement of the Median Glossoepiglottic Fold and Laryngeal View During Emergency Department Intubation. Brian Driver and Rob Reardon are both emergency physicians at Hennepin. Rich Levitin is a name I'm sure most of you have recognized in the airway world. And it's a great little study. When, in my experience as an airway educator, and likely in your experience as well, not engaging this median glossoepiglottic fold underneath which lies the hyoepiglottic ligament. If you do not engage that ligament fully, even though it appears that the blade might be at the bases of the vallecula, if it doesn't fully depress that ligament, you do not get the indirect epiglottic elevation that is often required for good glottic exposure. Now that's never been studied, and they took a look at this, which I think is pretty neat. So, and these are illustrations from the manuscript itself, and this shows you in sort of cartoon form what you're looking at and what the blade should be doing. So in the top left-hand corner in box A, it's showing you a sideways view of the hyoepiglottic ligament, which is the green structure, and you can see the MAC blade with the bulb at the end sort of creeping down to start to touch that structure. Picture B shows the blade starting to get into the vallecula. The operator has now identified the median glossoepiglottic fold, but the blade has not engaged that fold yet. And even as evidenced in the picture in C, if you advance the blade even further where it looks like it's touching it but hasn't actually depressed that structure, you still have a low-hanging epiglottis. It's only when you push and depress that structure does it elevate the epiglottis and expose the glottic inlet, as you can see in picture D in the bottom right-hand corner. In real life, what does this look like? So here is the median glossoepiglottic fold. You can see the blade there is not quite touching that structure. It's starting to depress it here, so there's a trace amount of epiglottic elevation. But if you push forward another ½ centimeter, it acts like a marionette string and lifts the epiglottis out of the way and uncovers the glottic inlet. Now, what did they do in this study? How did they analyze this? So what they did is they took 207 patients who had CMAC video evidence of the intubation. They removed 43 where the tip of the blade was really not in the right spot to assess this, or they couldn't determine whether the tip of the blade had actually engaged in the with the hyoepiglottic ligament. And they were left with 164 patients. 94 of those, you could see they could tell that there was engagement the entire time with the midline vallecular fold. 19, they couldn't tell, or perhaps it was on again, off again, and they included that group of folks in both groups just so it's even-steven. And then there were 51 patients where it was pretty clear by video evidence that the midline vallecular fold was never engaged during laryngoscopy. And what they did is they looked at the breakdown of Cormack-Lehane grade view and the percent of glottic opening score with each group. When you looked at the Cormack-Lehane grade 1 or 2A, you can see here that when the midline vallecular fold is engaged, 96% of the time, you would get a grade 1 or grade 2A view. A 2A view is when you see most of the chords, but not the entirety of the chords, but it's considered to be a intubatable view with high success. Same with a grade 1 view, of course. When the midline vallecular fold was not engaged, the percentage of grade 1 or 2A views was 87% with a 9% absolute difference. And when you went down and looked at each individual grade view separately, there was a 13% difference in obtaining a full grade 1 view. When you looked at the percentage of glottic opening, this is the distribution of POGO scores stratified by whether the fold was engaged or not. The left side with the orange dots was when the fold was not engaged, and the right side was when the fold was engaged. And you can see that there's a much larger clustering of high POGO scores in the blue group. The summary is highlighted by the diamond-shaped boxes on the side, orange and blue, and those numbers translate to a 78% POGO score when the fold was not engaged and 87% POGO score when the fold was engaged. Bottom line is, it is a key thing with laryngoscopic technique to engage that fold for glottic exposure. So Calvin's critical concepts for this: glottic view, we know, at least with a CMAC and other more standard geometry devices, glottic view translates to intubation success. This is common sense. If you can see the airway, you can put a tube in. If you can't see the airway, it's actually quite hard. Engaging the glossoepiglottic fold and the underlying hyoepiglottic ligament is key in maximizing glottic exposure. And when there's a technical mishap during laryngoscopy, you may be overseeing a trainee. This may have happened to you personally. And you've done everything that you can. You know the blade's in the right spot. You just can't get that epiglottis to elevate. It's likely because you just need to advance, or your trainee just needs to advance that blade another ½ centimeter to press that hyoepiglottic ligament, and suddenly everything comes into view. Okay, so those are the 3 studies. We actually finished in about half an hour, which is really terrific because we do have to do our special presentation at the end for the Airway article of the year. I think what I'll do now is just see if there are any questions, burning questions from anyone out there. Let's see. Will the slide set be available on the Airway site? Are we allowed to use this in the difficult Airway course with our students? That's a great question. I think generally these are not available for download, but I will perhaps let Terry get to all of you by email at the end, or make some sort of statement about that. While we wait for last-minute questions, I will let everyone know that a recording of this webinar will be available as a podcast at Spotify, Apple Podcasts, and wherever you get your podcasts. Just search for Airway World Podcast. And let's move on now, while perhaps other questions come in. Let's move on to our post-test. And I do see a couple questions have come in, so I will tackle those right after the post-test here. All right, so let's see how we do. Post-test question number 1. During CMAC video laryngoscopy, maximal glottic exposure, this should be fresh on your mind, just saying, is facilitated by A, using a size 3 instead of a size 4 blade, B, engagement of the median glossoepiglottic fold, C, applying extra lifting force into the mandibular fossa, or D, placing the blade tip under the epiglottis. Wow. Okay, so just so you all know, we've done a lot of polls over the years, and we do similar polling with some standard questions we do at the Airway course, and only one other time have we ever had a 100% on the correct answer in our polling. So kudos to everybody for getting that correct. That's a very, very unusual achievement. Post-test question number 2. Trauma patients intubated with DL compared to VL had higher rates of. Now, we didn't actually cover this in particular, but I'll tell you, and perhaps you can think about this as you're answering. If VL gives you better glottic exposure and better visualization, the chance that the tube goes in the right spot is likely higher as well. So armed with that information, what do you think the right answer is? If you're using DL compared to VL, what do you think happens more often? Is it crike, dental trauma, soft gel intubation, or hypoxia? And someone just had to put dental trauma in there. But no, the correct answer is esophageal intubation. Adverse events actually across the entire spectrum of adverse events that are recorded were similar, but esophageal intubation in particular as a standalone adverse event was significantly higher in the DL group. Okay, post-test question number 3. When intubating blunt trauma patients, which device provides the best chance of a first attempt success? A video laryngoscope, direct laryngoscope, a flexible endoscope, or an intubating LMA? Almost 80% voted, and yes, 91% of you said VL, and that is true based on the registry data we reviewed in the first paper. Okay, post-test question number 4. In ED patients, which of the following will not impact the rate of post-induction desaturation? Morbidly obese body habitus, pre-induction hypoxia, supine versus ramp positioning, or septic shock? Yeah, so in the paper that we reviewed, when patients were intubated with APOX in place, supine versus ramp positioning really made no difference. Now, septic shock, it's not as obvious as choice A and B as something that might directly impact post-induction desaturation, but critical illness certainly lends itself to more rapid desaturation, mostly because of peripheral tissue utilization. Okay, let's see if there are any more questions. Okay, we have Anand ask what age group this applies to. I'm not sure what paper that's in reference to. Maybe you could put that in there. Omar asks, you spoke of pre-oxygenation. We were ingrained with denitrogenation with high flow nasal cannula and PEEP. Are those terms interchangeable? So no, high flow nasal oxygen and PEEP are not interchangeable terms. But you are correct that the purpose of pre-oxygenation is nitrogen washout. And this is best performed one of two ways. If you can get away with ambient pressure pre-oxygenation, the best way is with high flow face mask, actually flush flow rate face mask oxygen, because based on Brian Driver's studies from a couple of years ago, that gives you the best single breath end tidal O2 compared to other modes of ambient pressure pre-oxygenation, such as a non-rebreather at 15 liters, simple face mask, breathing through a bag and mask device. So flush flow rate oxygen. Now, if you need to increase alveolar recruitment because there's intrapulmonary shunt, then yes, you need to put some pressure behind that to increase alveolar recruitment or leave some static PEEP. You can use high flow nasal oxygen and you can use BiPAP to accomplish that goal. And so patients you're having a tough time pre-oxygenating with ambient pressure, you should transition them to either high flow nasal oxygen or BiPAP. Okay, and Omar follows up with another question. What qualified as a first attempt success? Blade in the mouth was an attempt for us. Yes, and that is true. That was the definition we had for near. If you inserted the laryngoscope blade past the alveolar ridge, whether or not you attempted to pass a tube, that was considered an attempt. James asks, is there an angle for the ramp? So it was 30 degrees or higher, but they didn't measure it in the paper. People either wrote ramped or upright positioning, but there was language in the near registry that basically stated it needed to be 30 degrees or higher. Will the GlideScope MAC blade, this is from Anand again, will the GlideScope MAC blade result in the same result as the CMAC? So that's unclear. So GlideScope makes their traditional GlideScope handle, which is a hyperangulated VL blade, but they also make their MAC-ish type of blades, but they're not the same. They're straighter blades, but they don't have the same feel. They don't have the same glottic exposure as a CMAC blade, which really mimics a traditional Macintosh laryngoscope in terms of width and depth and length. The GlideScope straighter blades are proprietary blades that don't act exactly like Mac blades. So that's not been studied, so I don't know that for sure. And Carlos asks, any difference between different types of VL in terms of success, CMAC versus GlideScope? So yes, there is. So that's a great question. When you look at either category compared to DL. They both beat DL. The one thing that happens with the hypercurve video laryngoscopes is that sometimes tube negotiation through the vocal cords can be challenging because of the attack angle that the tube has to take as it approaches the airway. Now, there are techniques that you can pick up and skills and sort of tricks that get you over those hurdles, but it can impact your first attempt success, especially with folks who don't have a lot of glide scope or hyperangulated VL experience under their belt. CMAC consistently across different studies on emergency department patients has a first attempt success rate that's at or above 90%. Glide scope is close, but not quite the same. And part of it is because of that tube delivery issue. But they both beat DL. Andrew asks, what is the lowest oxygen saturation stoppage point for an attempt? So that's a great question. I don't know if that's related to a paper or just a question in general. What we teach at our Airway course is that we want people, unless they're right on the cusp of putting the tube in, because they now see the airway right at the point the patient got to 93%, then just go ahead and put the tube in. But if you're still searching for the airway and you've gotten to 93%, that's the point at which you need to pull out and reoxygenate the patient, and for two reasons. One, that's the inflection point on the hemoglobin desaturation curve where the sat starts to drop a lot more quickly. Is it at about 93% saturated or 7% desaturated? The other is that what's happening in the patient physiologically because of pulse sat averaging and a little bit of recording delay from the peripheral oxygen monitor is that the patient's saturation likely in the body is a little bit lower than what you're seeing on the monitor. So there is a lag. So for those two reasons, we usually recommend that 93% is basically the zone at which you need to stop unless you're on the cusp of putting the tube in. Okay, well, that's a good set of questions. I appreciate everyone's questions. I think what we're going to do now, because we need to leave 15 minutes for the award show, is we're going to follow up here. We're going to stop here. Remember that a recording of this webinar will be available as a podcast in Spotify, Apple Podcasts, and wherever you get your podcasts. Just search for Airway World podcasts. You will receive a webinar, as I mentioned, multiple times within 3 weeks, and our 2022 schedule of webinars will be posted soon. I want to thank everyone who joined today. We look forward to seeing you again in 2022. Happy holidays. Be safe.